I'm Chuan Wen from SGH Hematology. Today I'll be talking about thalassemia. Thalassemia is a very broad and complex disorder. This talk is going to give broad overview of thalassemia, focusing especially on adult population in this region, particularly Singapore. Normal individuals have one beta-globin gene on each copy of chromosome 11. More than 200 mutations affecting these beta-globin genes and their regulatory sequences have been identified, resulting in beta thalassemia of variable clinical outcomes. In beta thalassemia trait, one of the beta-globin gene is carrying a thalassemia mutation, and these individuals are clinically asymptomatic with only mild anemia and variable microcytosis. Carrying two defective beta-globin genes results in a wide spectrum of clinical manifestation, including thalassemia intermedia with mild to moderate anemia and thalassemia major with severe anemia that is transfusion dependent. There are also other hemoglobin variants such as HBE, which may interact with beta thalassemia mutations to produce beta thalassemia intermedia or major. There are two alpha globin genes on each chromosome 16. Clinical syndrome of alpha thalassemia is determined by the number of functional alpha genes present. In silent alpha thalassemia, one alpha gene is deleted. People with this condition are asymptomatic, but minority may have reduced MCV or MCH. In alpha thalassemia trait, two genes are deleted. These are asymptomatic carrier with their hemoglobin either normal or minimally reduced. MCV and MCH are reduced. Patients with HBH disease have three alpha genes deletion. Clinical features are variable. They may have moderate anemia with reduced MCV, MCH, hepatosplenomegaly, and jaundice may also occur. HB Bart's hydrops fetalis is an important cause of stillbirth in Southeast Asia. Fetus is either stillborn or die soon after birth. Alpha thalassemia may also arise from non-deletional mutations of the alpha globin genes. One common example in Southeast Asia is HB constant spring. Thalassemia is a major public health problem in Southeast Asia and hence the importance of its screening. The population at risk can be screened for beta thalassemia trait by performing full blood count, HB electrophoresis and other techniques to quantify HbA2, which will be increased in beta thalassemia trait. It may be difficult to diagnose alpha thalassemia trait with these tests, and DNA analysis may be needed. Screening can be conducted at antenatal clinics or prior to planning for a child. When heterozygous carrier mothers are identified, their partners are tested. If the partners are also carriers for the similar related type of thalassemia, the couple can be offered the option of prenatal diagnosis for severe form of thalassemia. Some methods of prenatal diagnosis includes fetal DNA analysis on amniotic fluid cells taken by amniocentesis in second trimester, or direct analysis of fetal DNA obtained by chorionic villus sampling done at 9 to 13 weeks of gestation. Symptoms of anemia and timing of the symptoms are important clues to the severity of thalassemia. In severe form of alpha thalassemia, symptoms and signs including hepatosplenomegaly occur in utero or at birth, and for beta thalassemia major, these occur few months after birth. Full blood count and peripheral blood film would show microcytic and hypochromic anemia. It is important to distinguish it from iron deficiency anemia, which in turn may also occur concurrently with thalassemia traits. Iron studies can help to detect iron deficiency. Separation of the hemoglobin fractions can be done with HB electrophoresis or high-performance liquid chromatography, HPLC. In addition, HPLC can also quantify the HB fractions. Staining of the red cells for HBH inclusion bodies may be helpful in suggesting a diagnosis of alpha thalassemia, but this is often not detectable in alpha thalassemia traits. In normal individuals, they are mainly HbA with small percentage of HbA2 and HbF. In beta thalassemia major, there is no or very low level of HbA and persistently high HbF level. Beta thalassemia intermedia may have the same results, but the HbA level can be higher, and the HbF level can be lower than in the beta thalassemia major patients. In beta thalassemia trait, HbA2 fraction is slightly raised, usually more than 4%. In HbH disease, there is increased HB BART in neonatal period, detected in about 20 to 40% of the patients, and there are variable amounts of HbH detected later in life. The diagnosis of alpha thalassemia trait and silent alpha thalassemia often only can be confirmed by DNA analysis, as the amount of HbH is often minimal and not detectable. In beta thalassemia, there is absent or decreased production of beta chains. Alpha chain production is unaffected, and hence leading to an excess of alpha chains. These alpha chains, in the absence of their partner beta chains, are unstable and precipitate in red cell precursors that interfere with normal red cell maturation. There is intramedullary destruction of red cells precursors, and hence ineffective erythropoiesis. The matured red cells that enter the circulation have alpha chain inclusion that interfere with their passage in the circulation, especially in the spleen. The spleen hypertrophies and results in splenomegaly. On top of that, the degradation products of excess alpha chains produce much negative effects on the red cell membrane proteins and lipids, resulting in rigid red cell with a shortened lifespan. Both the ineffective erythropoiesis and hemolysis results in anemia, and this in turn stimulates erythropoietin production that results in expansion of the bone marrow and skeletal abnormality. The anemia is corrected with blood transfusion with its own complications. The anemia associated with thalassemia may be severe and is accompanied by ineffective erythropoiesis, with bone expansion and extramedullary hematopoiesis in the liver, spleen and other sites, including paravertebral masses. Transfusion, the mainstay of treatment, has its own related complications, and these include transfusion-transmitted infection, mainly hepatitis B, C, and HIV, and iron overload. Iron deposition in the heart, liver, and multiple endocrine glands, including pituitary, thyroid, parathyroid, and pancreas, resulting in severe damage to these organs. In beta thalassemia, there is absent or decreased production of beta chains. Alpha chain production is unaffected, and hence leading to an excess of alpha chains. These alpha chains, in the absence of their partner beta chains, are unstable and precipitate in red cell precursors that interfere with normal red cell maturation. There is intramedullary destruction of red cells precursors, and hence ineffective erythropoiesis. The matured red cells that enter the circulation have alpha chain inclusion that interfere with their passage in the circulation, especially in the spleen. The spleen hypertrophies and results in splenomegaly. On top of that, the degradation products of excess alpha chains produce much negative effects on the red cell membrane proteins and lipids, resulting in rigid red cell with a shortened lifespan. Both the ineffective erythropoiesis and hemolysis results in anemia, and this in turn stimulates erythropoietin production that results in expansion of the bone marrow and skeletal abnormality. The anemia is corrected with blood transfusion with its own complications. Several methods can be used to monitor iron overload. Serum ferritin can easily be performed, and it broadly relates to the body iron. However, its prediction of iron loading can be unreliable, and there are conditions that would increase the ferritin level. Patients with ferritin levels of less than 2,500 microgram per liter, or preferably less than 1,000 microgram per liter, is associated with lower risk of cardiac disease and death from iron overload. Liver iron concentration can be used to monitor iron loading. Liver iron concentration can be measured by liver biopsy and MRI scan, FerriScan. SQUID, or superconducting quantum interference device, can be used as well, but it is not universally available. For monitoring liver iron concentration, the aim is for a level less than 7 mg per gram of dry weight. Cardiac iron is reflected by heart function test and can be measured by an MRI technique called T2 star, with the aim of cardiac T2 star of more than 20 milliseconds. Cardiac T2 star can detect myocardial iron loading before ejection fraction worsens. There are 3 types of iron chelators available currently, namely deferoxamine, deferriprone, and deferoxyrox. The different types of chelators have their own advantages and side effects as shown in the table. Generally, chelation should be initiated after the first 10 to 20 transfusion of ferritin level above 1,000 microgram per liter for the thalassemia major patients. Sometimes, combination of deferoxamine and deferriprone are given for patients with severe iron loading, especially of the heart. Thank you.